Okay, so thank you all for joining us this morning on today's webinar, which is Mental Health Technology, Overcoming Barriers to Connection. I'm Rebecca Friedman, the founder and president of Chorus Strategies, a public sector business development firm. And I'd like to welcome you all and thank the Healthcare Technology Consortium for hosting this event. The Healthcare Technology Consortium is a group of technology professionals which are inspired to make an impact on our communities with a mission to bring their expertise and experience to deliver leading and innovative healthcare services. So I'll get into what we're going to be speaking about today, but first I'd like to introduce Mark Ian, who is with us with Crown Castle, to just talk a little bit about his experience within healthcare technology. And he is from one of the organizations that is part of the Healthcare Technology Consortium. So he'll give us a brief introduction, and then we'll go into introducing our speakers and kick off this great conversation. Just before he does that, as we're getting started, I am going to encourage you all to ask questions throughout this session. And as sort of a test to asking questions, using the chat feature in it's probably the lower right of your screen, go ahead and start by putting in there something that you're doing right now to maintain connection with folks during this difficult and sort of unprecedented time. So just go ahead and type something in there, and that's where we're going to be sharing our questions throughout. So I'll go ahead and hand it over to Mark.
Thanks, Rebecca. First of all, I just want to thank all the leadership of the consortium for inviting me to speak today. I really appreciate that. And I especially want to thank everyone on this call today for taking time out of their busy schedules to talk about something so important. So let me introduce myself. As Rebecca said, my name is Mark Guillen, and I'm the Regional Director of Public Affairs for Crown Castle. So here is our new reality. The world is rapidly changing, and as providers of service, whether it be in telecommunication or healthcare, we have had to rapidly adapt to these changes, which seem like every day. However, in spite of these changes, some things have never changed. Our need to connect with one another, either as employees conducting business, as consumers, as neighbors and families, has remained crucial to all of our health and our survival. Connectivity is no longer a luxury, but it is crucially necessary for public health, public safety, and keeping families connected. So very critical that many now consider wireless infrastructure and broadband a utility. However, rarely do we talk about the importance of closing the digital divide, of equitable access to technology, and universal availability of the infrastructure to the underserved and to those in rural and remote locations. So in the world we live in now, where 95% of adults have a smartphone, and where the majority of those struggling with homelessness have a digital device, and our aging population is trying to stay connected during these times of stay at home, the goal has always been and continues to be to keep everyone connected to each other. So as health providers, what can we do to utilize this existing resource and all the technologies we have to continue to give the important care that we all provide in this rapidly changing world? And for that reason, this is why events like today's are so very important. And everyone on this call should be congratulated for making the time to participate. And so let's talk about mental health technology. Just last week, early last week, I was reading an article titled "The 5G Revolution and How Hospitals Are Tapping into Wireless Solutions to Enhance Patient Care." Hospital and healthcare systems are increasingly adopting telehealth and incorporating IoT devices. And I don't need to tell you all about how rapidly we are trying to do that. But this reliance on new technology has forced all of us, including our healthcare institutions, to address their aging IT and their in-building wireless services to a more updated model. And so this article makes some very compelling points that are particularly relevant for today's panel. And they are, firstly, that wireless is the fourth utility. Wireless networks and technology are now considered crucial. They are essential and reliable to drive the success in businesses, equity in our communities, continuation of the valuable care that we give, and resources needed to engage the new world in our times today. Secondly, the wireless connection is critical to healthcare. Wireless technologies is mission critical in the modern healthcare venues, including mental health service delivery. And it will be the avenue where care is delivered to many who cannot and should not expose themselves to the present dangers that we have today. The reality is that COVID-19 has shown a light on this reality. And as digital connections allow for social distancing and virtual connections, it will help to slow the spread of the coronavirus. And lastly, our new technology, 5G, the next generation of connectivity, will strengthen the patient experience, and analytics will empower patients to manage their healthcare with faster, easier access to their data. And the next generation connectivity will power remote, real-time monitoring tools that will allow clinicians to monitor local patients while also attending to remote patients. And this next generation connectivity will enhance a physician's ability to deliver improved diagnoses and less invasive treatments through new technologies like augmented reality, virtual reality, and artificial intelligence. So it is without a doubt, we are living through a crucial time in history. Our traditional systems and routines present new challenges every day, and we must continue to collaborate together and ponder these current issues together, using the resources and technology that we have today to create a strong future where all of us thrive. And so now, I'm particularly interested in hearing from our mental health experts and who will address the technological aspects of what's needed, what's possible, and what's coming. So again, I appreciate your passions for being on this call today, and I thank everyone for having me. Thank you.
Thank you, Mark. So, as you all know, today we're facing unprecedented challenges as we navigate the changes of COVID-19 and those that have been placed on our everyday routines and health. So many people are coping with significant disruption and increasing uncertainty about their health and financial security. Stress and anxiety levels are rising. Fear and anxiety about a disease can be overwhelming and cause strong emotions in adults and children. So how someone responds to an outbreak can depend on their background, the things that make them different from other people, and the community they live in. So today, these panel of experts in the mental health field with us are here to discuss how they're working to overcome barriers to connection using technology. I do want to give the disclaimer that we're not sort of technology experts necessarily. I think everyone wants to sort of put a quote around the technology expert. However, we are all practitioners and use technology, we're using it right now, as one way to overcome barriers to connection. So we won't get into, as people say, the bits and bytes in the discussion, but I think that we still will have a great conversation about technology and mental health. So this webinar will be 1 hour long. During that time, as I said, if you have questions about anything for our panelists, you can put them in the chat box. It should be on the right-hand side of your screen. And we'll try to get as many questions in as possible during the session today. So go ahead and get started with that practice chat. If you have a way that you are finding ways to connect with people regularly at this time, you can throw that in the chat just so we have a sense and we can all get ideas of how to connect with one another better. So I will get started by introducing our panel. So Dr. Ceth Ashen is the Chief Operating Officer at Gateways Hospital and Mental Health Center and the President of C. Ashen Consulting. Dr. Ashen is a clinical psychologist and works with children and adolescents, including foster youth, as well as families and adults. Dr. Thomas Parham, or Dr. P as he's known, is the president of California State University, Dominguez Hills, a highly diverse metropolitan university primarily serving the the South Central and South Bay areas of LA County. Dr. P is a licensed psychologist with more than 35 years as a scholar and practitioner. He's a prolific writer and speaker focusing on identity development, African psychology, and multicultural counseling. And Dr. Imani Walker is the medical director at Gateways Hospital and Mental Health Center in Los Angeles, so a colleague of Dr. Ashen. She specializes in caring for acutely ill psychiatric patients, including those with eating disorders, and providing mental health care to homeless and indigent populations. She has a strong personal focus on health and wellness, is the author of a forthcoming book, and is one of the stars of Bravo's Married to Medicine, a show which is certainly binge-worthy. And as we heard for folks who were just joining the call earlier, she's also the host of a podcast. So welcome to our speakers. So anyone want to add or clarify if I got anything wrong in their bios? I didn't NS those. Okay, good. Thank you. So welcome to you all. We'll get started with some kind of overview foundational questions. So what is the current state of digital mental health care in your work? And what have you seen represented industry-wide or maybe changing at this time? Start with Dr. Ashen.
So thank you so much, and I want to thank the panel for inviting me, and thank you, Rebecca, for coordinating. The work that I have been doing actually has been around evidence-based practicing, dissemination of evidence-based outcomes, and to community-based organizations really across the nation. And the different agencies really struggle in different ways. All of them have been moving more into the electronic realm. 6 months ago, the most common digital medium was really psychiatry, telemedicine, and other mental health was really home visits and community visits, school-based, clinic. And now we are obviously seeing a combination and a hybrid of, digital, the continuum of digital mental health care, telehealth. So currently, the reliance on electronic health records and becoming more digital, relying more on that environment as well, is what I'm seeing across agencies.
It's interesting. There's obviously so many similarities, but every industry has its own language, right? So you were mentioning evidence-based within your industry. I think that's almost the same as data-driven decision-making, which we hear so often now used within kind of the technology realm. But industry-specific language is so important, and I think that there's absolute alignment to what you're speaking about there.
And I'll say that data-driven decision-making is also in behavioral health. It needs to be more in behavioral health, and it's where we will share common ground with technology and behavioral health. We're in our toddlerhood, I feel like, in that area specifically. So we have much to do together.
Mm-hmm. Yeah. So Dr. P, I'm interested in hearing from you on sort of the current state within your work. Obviously, you work with students, so you're not providing clinical care at the moment. But why don't you tell us what you're seeing within
your cousin from the West Coast.
Oh.
Yes, good morning. Sounds like we got some other chatters.
Yeah. Just mute our speaker.
We invite folks to mute their speakers. But I want to say, first of all, thank you for having me and welcome to all of our participants. I've not been in individual private practice for the last couple of years, particularly taken over the reins of being the president of California State University, Dominguez Hills. And so in that space, I think it's a little bit different. But when we think about how has COVID impacted, the practice? One, as a university, we've had to convert to a principally virtual and online format, which has done a couple things. I mean, I've argued that what crisis does, ladies and gentlemen, is it reveals character in people. Crisis exposes weakness in an organization or entity, and crisis also provides opportunity. So for us at a university, it certainly revealed character in looking at how people respond, but it also exposed weakness. And one of the biggest weaknesses for us was in our technological infrastructure. And so it's been a challenge for us to look at how do we provide both online, Zoom, virtual, and some limited kind of face-to-face interaction in the midst of COVID, and then challenge ourselves to do that. But it's also challenge the technological sophistication of the faculty, staff, and students. so that there are some faculty who don't teach online at all. So having to, gear them up to be able to do that, I think has been a challenge as well. And I think in terms of our clinicians, both in our student psychological services as well as our healthcare facility, Student Health Center, it's challenged them to provide, I think as Dr. Ashen talked about, not simply the telepsychiatry, which was probably more prominent, but even the telepsychology in that space that's been there. And it's also, I think, exposed a really question that we're still interrogating and not many people are talking about in mental health technology, is given the subtle nuances that you have to have in working with populations that are very culturally diverse, which is what I have on my campus. We have 90% of students of color on the campus, and traditional modes of engaging with patient populations are very different across different cultural demographics. And so the impact that technology is going to have on working with them and the efficacy of our treatment in working with those populations, I think has yet to be explored, but it's certainly something that we are concerned about and attending to.
Yeah, that's a great lead into a next question that I'll ask both you and Dr. Walker. If you could share a little bit about how the region, the urban or homeless population, access to public transportation as well, impact your view of the challenges in the field of mental health, and in your case, what's sort of evolving rapidly. I think when we think of traditional mental health, we may think of people who are already seeking care, kind of going to an office and laying on a couch, but working with students, you're seeing a rapid change in the past 6 months of the needs that are defined. So how is the kind of region defined some of that?
I will speak a little bit on, I guess, the patients that I do treat, which are mostly forensic patients that have a forensic history. So they've either spent time in the state mental hospital, or they've been they may come directly from Twin Towers or other correctional facilities, or they may come to us just from the hospital, from an inpatient facility. But I was really I was really concerned about, not just how do we make this work, but will these patients be accepting of having their clinicians be in a little box? Because when it comes to psychiatry or psychology, a lot of what we have to read is like what we see and what's body language. And if all of us are essentially coexisting in a little rectangle all day, or maybe if we're lucky, we can turn it, sideways, vertical. I used to always say, I have about maybe 5 minutes to get a patient to trust me in person. But now we're talking about, someone who sometimes I'm dealing with very, very delusional people. And I was really concerned that they might think that I was a figment of their imagination or something else that, may be, equally delusional, but would completely make sense under the circumstances. And the one thing that I'm really surprised by is that there are patients who, they woke up at Atascadero, let's say, and by the afternoon they're at Normandy Village, one of our facilities, and they really have been very open. And I think in some cases, because I'm trying to figure out why this may be, but I think in some cases it actually makes the patients that I see a little bit more articulate and a little bit more able to tell me exactly what's going on. And I think that, for whatever reason, I'm very pleasantly surprised, just to kind of echo what Dr. P had said earlier. I think that, in terms of crisis, we've all been able to show our strengths and weaknesses, but mostly strengths. But when it comes to the patients that I've been interacting with, I was really, really surprised at how well they were able to take to, all of a sudden it was like, okay, now all of your clinicians are going to be on the phone or on an iPad. So, but they've been actually very, very to adapt to it.
So speaking about sort of just overcoming the barriers, and it's great to hear that there are positive outcomes coming out of using technology as well. Are any of you seeing that the accessibility of, because we mentioned a little bit about public transportation, you're all based in Los Angeles, in most cases urban area, which can have traffic issues even now. is the ability to connect to people in their homes or in their own space, has that in some cases provided an additional opportunity to connect with them?
I mean, for us, you know, it has, when we think about the biggest challenges, I guess, in trying to implement technology solutions, I think there's several for us. One is, it's an interesting assumption that everybody even has a computer. There are a lot of our students who are so economically challenged that they don't. So on the university campus, we have a technology loaner program to make sure the students can either A, use a computer lab, or B, check out a computer themselves to be able to keep up with their work. So when we're now COVID and physical distancing, how do you even get access to, right, the computer? There's some folk who have the equipment, but don't have the bandwidth to be able to even get the proper you know, wireless signals, et cetera. So they're used to running from their home to the Starbucks or someplace else because home doesn't have it. Well, now Starbucks is closed, so they can't even get online with that. So I've had students get as innovative as actually getting out in their vehicles, right? And holding it down out in their vehicles because the home environment is either not steady relative to signal, or it's too toxic for them to be able to conduct any kind of business, be it classroom or healthcare or otherwise. And so it really has exposed, I think, the digital divide that exists, as well as us having really insufficient resources to be able to manage that. So I think that's a challenge that we have to pay attention to, particularly in urban areas, because as Dr. Walker said, people, I think, are surprisingly responsive to that. And particularly for us old school clinicians, where I wasn't really a fan of telehealth or telepsychiatry back in the day, because I'm used to paying attention to the idiosyncratic behavior of the patients that I see. But people have surprisingly adapted to it, but that assumes people can even get access to it, which they can't. And so we have to really pay attention to that and make sure that if we're in this space, that we can close the digital divide between our clinicians and the patient populations that they see, and not assume that everybody has the same proper equipment that we do to be able to get access to them.
Yeah, which speaks to that digital divide, speaks to, you know, what you had said in the beginning around gaps in technology and broadband access, as well as that sophistication in use as well. So it's interesting. I will say we have some technology practitioners on the call as well. So if you have any requests for call for help, we can also make those to them later in the call. There's certainly, you know, a lot of support from vendor communities which are required to implement different solutions. So I'll jump from there over to sort of implementing solutions. You've all been required to rapidly implement different solutions, as well as processes and procedures to address providing mental health care services, so regulations and leadership within your own organizations possibly, as well as budget. How have you faced down some of those? And I'll direct that first to Dr. Ashen, your role at Gateways. I think, you know, you are responsible for a lot of that decision making. How have you worked with your organization to take on some of those changes?
So we at Gateways have a solid technology department, IT department, which is great, but Dr. Parham is right on target in talking about the struggle for resources. So while we have a wonderful technology department that has helped to onboard staff and take computers that are older and try and, I don't know, revitalize them and pass them to people that are in need, clinicians that are in need, to do remote service delivery, it has been somewhat challenging in terms of resource management. So that's a call out to anybody in terms of the technology resourcing needs there. The other challenge that I would say that has occurred is this idea of leaning in and being with a client and clients in a very different way, where there's a screen between us. I'm so grateful to technology. You know, as Mark, you said earlier, I couldn't be more grateful that we have these vehicles, 5G and technology to be able to connect. At the same time, our technician, you know, our practitioners are really struggling, I think, to learn how to be practitioners behind the screen, to be able to evaluate, support, and that learning curve is happening. Where do you press on the video button or the mute button, or how do you share the screen? Those things are very That was like 4 months ago, and now it's, Rebecca, I don't know if a tear is falling or not, but I'm interested in knowing more. Help me know where it is that you are so that I can support you. So I think that the challenges are going to continue in that realm, and I think we need to be innovative together, technology and behavioral health, to think of solutions and platforms where there'll be more widgets that will help us to lean in and connect more readily. And I don't even know all of what that looks like, but I'm excited to be at this juncture because I do think we're reaching a crowd of people that we were not able to once reach. At Gateways, we were once able to reach a certain number of people, reaching those number of people, and maybe some of those mothers that couldn't get in because she's got multiple children, has to get 3 buses to get to the clinic, or doesn't really want us in her home because she's embarrassed about the studio living. And now the virtual platform has offered up a time and a space for her to be able to get the support she needs and the kids to get some of the support they need, but we still need to get better at leaning in technologically.
So can you speak a little bit specifically, what solutions are you using now that you weren't using 6 months ago, other than the obvious Zoom or video chat interaction? Are there other actual implementations you've made to process or technology?
Yeah, so Zoom, we're not using Zoom actually, we're using Teams. Each agency picks its own based on.
We sometimes say Zoom now in the way that we say Uber, right? Rideshare, Uber.
It's true. And Zoom is happy about that.
Yes, I'm sure.
So we have used, we're 100% electronic now, where we weren't before. And what does that mean? The whole assessment intake is now online. And in order to do that, we're implementing DocuSign. We have now remote desktop companies, third-party companies that are HIPAA compliant that we've engaged in so that people can use their computers off-site and be able to get in and to stream. And there's other bells and whistles with technology, drawing features, applications and apps that practitioners are engaging in to try and really engage clients. So, and we're looking for more resources on that front. And our platform is not sophisticated enough, and Zoom or any of them are not sophisticated enough to really do all that we need to in behavioral health. So I know that question is coming later, but I'm excited about the prospect of the development of platforms on that front. We're not there yet.
Yeah. Dr. Walker, I think when we spoke previously, I think it was you who mentioned that you're seeing patients use some of these different tools simultaneously and some of these interactions. If you could speak a little bit about that, I thought that was really interesting, and some of that varies with age group or technology comfort level.
So luckily, the patients that I see at our Gateways facilities, IT has provided each site with an iPad or the capability to use. We use Microsoft Teams, which is like Zoom, to be able to see our patients. So I have actually heard of. I no longer work with our homeless program, but I've actually heard that. A lot of the patients are seen by clinicians on their cell phones. So that has actually, I think, in a lot of ways increased I can't think of the right word right now, but basically it's increasing the rate of these patients being able to make their appointments, because now we don't have to deal with, or at least these patients don't necessarily have to deal with public transit. And I think it's also been nice that it somewhat levels the playing field, for example. So there may be someone who, they don't want you in their house for whatever reason. And now, because you can only see them within like a certain area, they feel a little bit more comfortable discussing how they're feeling or what's going on. In terms of multiple platforms, when I'm not able to use Teams, for example, because the patient isn't in a facility, I've just pretty much been calling them on the phone. And like Dr. P said, I really was kind of iffy about telepsychiatry pretty much up until March, when when the stay-at-home orders
you were given no choice.
Right, exactly. And actually, it's been, I mean, it's been really positive, but what I was trying to say is that whether I'm on the phone or whether I'm actually like seeing them, I feel as though the interactions have pretty much been really good. I think the patients have been able to really adapt to, you know, different modalities of now having to see their clinicians. So yeah, pretty much for me, it's been telephone, or it's been like video conferencing or video chat. And yeah, they've been able to adapt to it as well as the clinicians have been able to adapt to it really well.
Dr. P, you know, you're working in a university environment. I'd love to hear, especially from you, you know, what value you see from working with similar organizations or government organizations that you work with and support you, or in fact, just similar organizations that you're seeing are addressing some of the same challenges. How have some kind of consortium efforts or conversations with colleagues helped to move things forward for you in this space?
Yeah, great question, Rebecca. I mean, for me, I think there are a couple things that come to mind. First, as a administrator for lots of years, one of the techniques I think is always great, which is what they used to call manage by walking around. So taking a look at what other people do, I think is always smart. So there's a lot that we can learn even in a university environment that has a level of arrogance to what it is we do, you know, being in academia, that there's a lot we can learn, I think, from our partners. And so we are engaged in trying to develop what we call strategic partnerships with various people to help us both meet our needs, but also create this reciprocal exchange that we can, you know, get with folk that help us both to meet their needs as well as them helping to meet ours. So those kind of strategic engagements, I think, will be important. But for me, I think I want to be a little bit cautious, and time will tell, because even as we react to the crisis, what I don't want us to assume is that crisis somehow is equivalent to normal, because I'm not sure that that is. For example, in one of the books I wrote years ago, I coined a phrase that said that healing is therapeutic, but not all therapy is healing. And it was really meant to really talk about the context of cultural competence and cultural proficiency, because there are some kind of therapeutic modalities that we might be able to use that is actual therapy, that is assessment, that is testing, that is whatever, that in fact are designed to produce a certain outcome, but with a particular patient population that may be culturally different, you know, they may be there. So we've got to be able to take a look at that and look at the ways in which technology is really impacting what we do. I mean, the old school clinician in us used to be able to use not only the view of the idiosyncratic behavior in the patients we see, being able to confront mild inconsistencies, being able to do those things and looking at the reaction and the inconsistencies between the verbal and the, you know, the behavioral in that space. But also we were able to really just connect with them in both behavioral and even spiritual ways. I'm not talking about religiosity here. I'm talking about that energy and life force that is there. And so what technology will do ultimately is expose, I think, the cultural competence versus incompetence of clinicians in that way. So we've got to be cautious about that, but it'll also challenge us to provide much more authentic connections with the patient populations that we are looking to see and treat. And hopefully that we can produce via technology the same results that we were producing when we were seeing folk face to face. And that, I think, becomes the interesting challenge. So even as we engage in those strategic partnerships and engage with folk out in the world, part of what we'll be looking for with that cautious optimism, though, is trying to see whether or not they're able to master those elements of the therapeutic world as well.
Within the CSU universe that you operate in, are there other folks that you are working with who are addressing these particular challenges?
We have not had lots of conversation, but we do. So within the California State University system, which I bring you greetings from, there are 23 campuses in that system. It is the largest system of public higher education in all of America, as you know, educating almost, 490,000 students a year across the 23 campuses. So I have one of those campuses, about 17,000 students. But within our divisions, we have a division of student affairs. And so the student affairs folk talk to other student affairs people across those 23 campuses, and the mental health providers. We have an excellent person who has just taken over after the prior director retired, Dr. Tiffany Herbert, who manages our psych services there on campus. And so she is in contact with her colleagues across the system and within systems, because we also have access to colleagues both in the CSU as well as in the University of California system that help us out, as well as clinicians that work out in the community. So there's a nice network of folk there, in addition to what they have with their professional organizations. Certainly the American Psychological Association is part of that, the Association of Black Psychologists, et cetera. There's a National Latino Psych Association. I mean, there are other folk who provide that network, and that's, I think, where they are consulting with to find out what are the best practices and being able to achieve the results we want.
Great. Dr. Ashen, I'd like to address the same question to you. So what value are you seeing in these similar or dissimilar organizations? Gateways is an organization which, correct me if I'm using the wrong terms, but sort of operates within the county atmosphere, LA County's atmosphere, and receives referrals from the county system. So could you speak a little bit to how that support has driven some of the technology efforts that you have in the organization, and also where you're seeing some of these data-driven decision makings being applied to the organization that you're in? You're on mute. Hold on. That's our first time. It's like playing bingo. There's always got to be one time.
Sorry about that. I was wanting to be respectful. I think that in terms of LA County, and in terms of the kind of the different providers within LA County, the amount of support that is given to each of the providers, one of which we're one of the contracted providers of LA County, each provider is really on its own to try and figure out how to best deal during the time of COVID, how to treat our populations, our communities. And in terms of the data and data driving decision making, we are still where we once were 6 months ago, a year ago, 10 years. I mean, I feel like we really need to move forward, and this is where technology really, the rubber meets the road here in a very good way, figuring out ways in which to make our electronic health record work for us to help us know if what we're doing really is working or isn't working. And we would rely on that, and are relying on that now, much as we were in the past. And each of our systems, each of our sites really look to provide the amount of, service delivery that's commensurate with the treatment that they're needing. And then we do outcomes based on each individual's service deliverable. So right now, in terms of the COVID, we're really relying on the platforms that we're using, still relying because we're an essential service doing live service delivery, and embedding our results from that which we're doing back into our electronic health record. But hopefully part of the silver lining of what's going to happen with the shifting of platforms is we're going to be able to support our clients in a different way, and then glean from the service deliverables that which is working and that which isn't, to then drive not only decision making on the individual front, but even on the therapist front. How can we be more helpful to our therapists? What do they know? What don't they know? What are they struggling with? And then on a system front, right? So we have much work to do still on the data-driven decision-making, because we need to get better at gathering data. At Gateways, we need to get better at it, and as a system of behavioral health, I think we need to get smarter and work harder at that.
Yeah, that's it's interesting, and you bring up a really great point about checking in with your own teams, with your own practitioners, right? Every individual is facing a lot of the same challenges. So you're dealing with a lot of new things at work and new experiences that are stressful, but we're also all dealing with the same kind of current environment around COVID-19 and the additional pressures, including some practitioners who are now working from home, and also sort of homeschooling or becoming teachers in addition to their normal career. So is that something that you've adapted into your practice to do regular check-ins? I know we had a sort of chat going about what people are doing to maintain their own connection.
Yes, you're making a great point, and it's become such a part of the culture. So regular flash meetings, there's regular supervision. Client care has now moved to, rather than 1 hour, or a 50-minute hour, multiple times a week, maybe 20 and 30 minutes at a time, but multiple times a week spread out so that it's more supportive throughout the week. More caregiver involvement than ever before, which I think is also a silver lining. It isn't even so silver, it feels gold to me. And then, figuring out how to reach those more difficult to reach populations like Dr. P was talking about earlier. It's very difficult when some people don't have that accessibility bandwidth. And in those cases, we are going out and as an essential service, meeting them physically where they need to be met as well. So, but yes, the teaming that's happening now is happening more now than ever. And I hope that this is one of the silver linings that stays for the duration. Much like the 100% electronic health record now is going to stay in as a gift for us to be able to see people, open them, see them remotely, and close them all in one episode of treatment. And we might not have gotten to that severely depressed client. Now I feel like the teaming piece and our call to action and being thought partners together and strategic partnerships, like Dr. Parham, you are also saying, I think is critical even within our agencies where sometimes we can silo. This is now called to us, so heroes rise and fall in the face of crisis. Maybe Dr. P, I'm quoting you on that. And I feel like we as leaders need to really lean in, and 5G, Mark, has totally helped. So, yeah.
It's great to be in an area where 5G is available. Absolutely. That's fantastic. Yes. There was one comment in the chat around special education, and you'd started talking about some of those more vulnerable populations. So I'd like to address the question to both you and Dr. Walker. This is something that we can't quite predict yet. Some of the data-driven decision-making and AI is going to help to determine some of those things, but we're hearing a lot about less reporting of child abuse, for example, which is related to not having children having as much access to mandated reporters, most likely. So it's not necessarily that the cases of child abuse or neglect have been reduced. So that is, as well as individuals who are entitled to but receiving less perhaps special education or other things that they require to operate in their daily lives and to thrive. How are you concerned that will impact sort of future outcomes of your industry? I'll start with Dr. Ashen, but I'd like to hear from Dr. Walker as well on that.
So I don't know if I'm getting the question correct, but if I'm getting it right, you're wondering how the lack of our ability to be close enough to kids to see if they are suffering, our caregivers are really suffering, frustrated and abusing their kids because they are also so frustrated that we're not going to have access to them to be able to.
Yeah, it's also just long-term outcomes. I think that we're only kind of starting to realize what we're in kind of reactionary mode still, I think, in a lot of organizations, particularly in healthcare. But the concern about long-term outcomes has started to come forward a bit more, especially as the traditional school year would have been starting around now. But certainly there are other populations that fall into the groups of those who aren't receiving the services they normally would.
So my concern, on the short term is the first, which is, my concern about who aren't we seeing and how are we not able to reach them, and the way in which we're dealing with that at Gateways and at other mental health agencies is to try to be proactive with the school counselors. Davey asked a question about school counselors and how are they going to treat kids. In LA County, kids are still at home, and so those wellness checks that they speak about now, multiple digital wellness, right? Multiple touching base and giving permission and providing an outlet almost in a early intervention method is what we're trying to do now, reaching out to our caregivers and having them have time on the phone as well, time on the screen as well, to be able to have their own time and space to mitigate and help them to know what to do differently, how to provide their own self-care and implement their own self-care so that they don't, it's very hard. It's hard not to lose it when there's so much stress and so much crisis. And me leaning into that too, and being compassionate about how they're feeling and helping them to connect to other adults, helping them to know where they can go and have their sip and chat at a social distance like you did, Rebecca, and you're doing. These are things that don't come maybe so naturally when our caregivers are in crisis, but those are the kinds of things that make a difference between how the evening goes, well, it doesn't go so well. So, and my hope is that then that will impact then the longer term outcomes. If we're leaning in now, then the outcomes are sure to come hopefully later if we're doing the good and right thing right here, right now. So, but there is a divide, and that digital divide that Dr. P spoke about keeps me up at night. I don't know how to close that, and we need partners to be able to be forward thinking and moving kind of quickly as we build this plane in flight together.
Go ahead, Dr. Walker.
One of the things that, one of the first things that entered my mind when we entered into this pandemic is the fact that I knew that there would be a lot of underreported domestic violence assaults, and also child abuse, neglect or assault. And we have been seeing that. We have an adolescent unit at Gateways at the main hospital. And yes, the numbers have definitely decreased, sure, because it's summertime, but we still would have been in session back in March through June. And so our census on the adolescent unit has naturally fallen. That being said, I have said this repeatedly, and I know it sounds really grim, but I believe it. But I believe that we have already entered into probably one of the worst mental health crises nationally, if not globally. And just to kind of make a point there, we don't deal with detox or rehab patients, but I actually do work at a facility that handles those cases. And because there are people who, because there are rehabs that are, generally can take, let's say, up to 18 beds. Now you not only can't have the same amount of staff, you can't admit the same amount of people to be potential patients. And so we're seeing, people who, are used to dealing with not a lot of money, and now they have no money at all. Now we're dealing with people who, it's easier to self-medicate than they might feel to be able to actually go pick up a prescription. So I'm really, really concerned about what the mental health landscape is going to look like in 6 months, and what it's going to look like in a year, because we're seeing just some unprecedented levels of symptoms in people who have previously had mental illness and people who maybe not have reported any mental illness at all. So while I'm very glad that the technology is available, I think that somehow we need to collectively get the word out that those mental health services are there. I don't want for people definitely to think that, well, I can't, COVID's so rampant, I don't want to go to the ER. I don't want to go report if maybe I'm feeling suicidal or something similar. So I've been on the lookout for that, but I think it's going to get much, much worse before it gets better.
Mm-hmm. Yeah, and unfortunately, but and that's what we're hearing about a number of things, right? We're sort of in the middle of it at this point. So a lot constantly evolving at the moment. So I'm not seeing any questions at the moment, but I do have some questions that I will ask our speakers as we wrap up. Well, I have Dr. Amani on my screen anyway. I will start with two questions. So one, what's one thing, if budget was not a constraint and resources were not a constraint, it's not just money, it's oftentimes the individuals to perform the work. what is one transformation you would implement in your practice or organization? And then also, what's one resource that you would suggest for individuals who are on the call around mental health and the mental health industry?
If there were no budgetary constraints.
Yeah, you're dreaming big.
You know, if there were no budgetary constraints, and if there were, you know, if we could just trust everyone automatically to do the right thing. I really had not thought about being able to provide what Dr. Parham was discussing, students with technological devices. And I think it would be excellent if budget wasn't a question, if budget wasn't an issue, that we would be able to provide that for our patients as well. So that if it's a situation where, you know, not every mental health crisis necessitates, you know, going to the hospital or going to an ER or calling a psychiatric, response team. I think it would be, you know, nice to be able to provide maybe doctors who are on call. If someone's having an issue like after hours, I would love that if patients were able to, you know, similarly to calling a service and having to wait for the doctor to respond, if we were able to somehow be able to provide our patients just like, you know, help with maybe lower level crises, like just immediately. And then as far as resources, you know, I do wish that, especially, I think the biggest thing honestly is, you know, we're in the beginning of the pandemic, I personally saw less homeless on the street because they were given places to stay. But now, you know, it's August, we're 5 months in, the weather is crazy. Like what we really need we really need housing. We really need housing for people. We really need to know that, like, for example, I was talking about maybe people who are going through domestic violence issues. You know, if that were happening to me, I was thinking like, well, where would I go? Like, is it safe to go to a women and children shelter? Like, who do I call? Like, how do I get there? Like, and a lot of people, I believe, are dealing with abuse, unfortunately, because it's safer for them to be at home than it would be to be outside. And so I really would like to see just more resources where people can feel that they will be safe, not just from the virus, but just safe from whatever type of crises they're dealing with.
Right, so next, Dr. P, I'll ask the same questions to you. So one thing, if budget and resources were not a constraint, and then also one resource, and that resource can actually be your own book if you want, that you want to offer up to people, or your own podcast. But what are something that would be on your wish list and something that you want to offer to folks who are on the call?
So Rebecca, I'm going to try to answer this and hopefully that I don't get diagnosed myself as being delusional about, you know, what.
I'm not a clinician, so I can't.
But I want to answer that and also pick up on something Dr. Walker was saying, which I think is an important point we don't want our guests to gloss over. To me, I think the solutions can be both tangible and intangible. So when I think about tangible resources, what I love, you know, it's kind of like we want a chicken in every pot. I want a computer in every household. I want a technological device in the hands of everybody that would allow them to be able to access the services in the way in which we're doing remotely. But I also think that what we need is some intangible solutions that in some cases are common sense, in some cases are the ability for all of us as members of the human family to just, you know, care for and reach out and really take care of each other. I mean, Dr. King was clear when he argued that we are all caught in an inescapable network of mutuality and tied to a single garment of destiny. You know, that saying has been no more illustrated and clear than it is right now in this pandemic. And even as we saw in mental health data, if you look at the data, depression has been replaced by anxiety is probably the #1 issue going up, and it's certainly enhanced now. But even if you look at the post-traumatic stress that is coming on from people who are literally dealing with COVID, and we don't usually associate post-traumatic stress with COVID, but this is literally life-threatening stuff that folk are doing. So even clinicians are having to adjust our own thinking about what does this represent? And then you couple that with the racial injustice on the street. So me being a Black man walking down the street, it could cost me my life, right? If I get stopped by the wrong police officer in the wrong place in the same way George Floyd, Ahmaud Arbery, or Breonna Taylor did. When you think about the financial challenges people have of losing jobs, you're looking at those of us who do that stress research are talking about the life change units that are compounded in a way that then lead to more physical illness. There's so much out there that is there, but what we need are intangible solutions as well, where we just engage in really caring for one another in a way in which is very different. And lastly, I'll say that even with respect to our school systems where people are struggling with that, I think one of the questions you asked earlier was about school counselors and what do we do? School counselors are going to have to adapt the same way that clinicians are outside or presidents are at universities in having to deliver that service. But what we've got to do, I think, rather than engage in a litigious society about you aren't providing my care, I mean, some of those services that we have for our students are legally mandated. And we also know that a lot of referrals to mental health treatment come from two primary sources in the community. One is the school, the other is the courts. So that is not going to change. But the challenge for us is to figure out not how do we sue to get what we want, but how do we engage in authentic conversation with people in those strategic engagements to get together to figure out how can we best provide services for those who are physically needy without having to go through the court to be able to get it done. We're all in this network that we have to be able to do this, so we need a little bit more compassion as well, in addition to the tangible assets that we need, like devices and bandwidth, et cetera, to be able to help move us through this crisis.
Thank you. Yeah, I think that that's an excellent point, and we'll go ahead and actually wrap up from there because we are at the end of our time. But I think that that really addresses what we're here to talk about today, which is that this is not a burden that falls on just one group. This is not a responsibility that falls on one group. Certainly, mental health providers, healthcare providers in general, play a huge role in supporting this, and technology providers, of course, as well. But this is a community problem, and it goes beyond, of course, what we're facing with COVID-19. So I think, I really appreciate that statement to wrap up this talk. I really want to thank you all for your time. Mark Ian, Dr. Ashen, Dr. P, and Dr. Walker, thank you for being here with us today. I hope all of our attendees enjoyed this session today. Thank you again to the Healthcare Technology Consortium for bringing together this event. Let's all try and use technology as a tool to overcome barriers to connection. Let's do our part to help bridge that digital divide, particularly those folks who are within the technology industry. And I'll just say, be well, be safe, wear a mask, remember to complete the 2020 census, and vote. So thank you all for joining us.
Thank you.
Thank you all.
Thank you.
Bye.